Okay, hello, good evening. Today again, our second session about second part of post-operative and critical care eMRCS Zoom discussion. We finished half of the questions a few days ago. I'm sorry, I was a little bit busy. And so today we'll continue to finish the second half. I hope you revised the first half of the lecture, because most question in the second part will be mostly repeated and many same scenario and similar scenarios with similar ideas. Okay, so as we used to start, we exactly. I think we had this question last time. Let's start from this question. Okay. Yeah, let's start. Dr. Ghada.
A 51-year-old man is shot in the abdomen and sustains a significant intra-abdominal injury. A laparotomy, bowel resection, and colostomy are performed. An associated vascular injury necessitates a 6-unit blood transfusion. He has a prolonged recovery and is paralyzed and ventilated for 2 weeks on intensive care. He receives a total parenteral nutrition and is eventually weaned from ventilator and transferred to the ward. On reviewing his routine blood tests, the following results are noted. Hemoglobin 11.3 gram, platelets 267, YPC 10.1, urea and electrolytes, sodium 131, potassium 4.6 millimole, urea 2.3 millimole, and creatinine 78 millimole. Liver function test, bilirubin 25 micromillimole per liter, alkaline phosphatase 445 unit, and alkaline ALT 89, gamma glutamate transferase 103. What's the most likely underlying cause for the abnormalities noted? Delayed type blood transfusion reaction, bile leak, anastomotic leak, total parenteral nutrition, or gallstones. For this history, there's abnormality here in liver function test. Bilirubin is obviously elevated. Yes, elevated with elevation of liver enzymes, including alkaline phosphatase. So, with the finding, he received 6 units of blood within 2 weeks. So, no features for delayed transfusion reaction. For alkaline phosphatase, it's elevated, but there is no features of bile leak because there is no fever and triglyceride. There is no tachycardia, so no anastomotic leaks, either gallstone or because of TPN. I think it's due to TPN because one of its side effects is derangement of liver function regarding his blood count and urea electrolyte within normal range. So D option more precisely to be the option.
Perfect, Dr. Ghada. Here he wants to give you or test your idea about that TPN for a long time causes derangement of liver enzymes. That's why people on TPN up to twice time weekly, they doing liver enzymes. Sometimes if it's the start of treatment once weekly, and if it's in the middle, maybe up to twice or 3 times weekly, doing liver enzymes to check for the liver status, because TPN causes derangement of liver enzymes.
Yes.
Okay, this is very important to know here and to know in part B when going to surgical nutrition. One of the complications You will be asked in the exam about TPN. What's complications of TPN? One of them is rearrangement of liver function test and liver enzymes. Okay, next question. Dr. Sarah.
Okay. Which statement regarding post-operative cognitive impairment is true? You have a use of benzodiazepine, preoperative, reduced long-term post-operative cognitive dysfunction. Pain does not cause delirium. Delirium has no impact on length of hospital stay. A regional anesthetic rather than a general anesthetic is more likely to contribute to post-operative cognitive impairment. Visual hallucinations are not features of delirium. Post-operative cognitive impairment is true. Operative reduced long-term post-operative cognitive
It's a little
functions.
bit difficult question, I know, and it is not very recurrent and not very famous question. And we have no other related question to this question. Just the answer. You can guess the answer, or you know it from your study before?
No, unless I just try to reason and then look at them and reason. I've seen many.
I think many of your friends who already started before.
Use of benzodiazepine proactive reduce long term. Can they please explain?
I tell you some question like related to pharma question is you can know it by exclusion in the exam, or some question are repeated as it is. And this question I didn't see it for a long time in recalls, but here is eMRCS. eMRCS is adding new question but not removing old question. Whatever, as Dr. Ghada said and me said, you can use it by exclusion. Which statement regarding post-operative cognitive impairment is true? Use of benzodiazepine pre-operative reduced long-term post-operative cognitive dysfunction. Okay, this is the answer. Let's go for the other answer. Pain doesn't cause delirium. I think it's wrong. Pain makes disturbance for the patient post-operative, and one of the best approaches to decrease the patient cognitive problem, and sometimes if the patient is irritative and have some convulsions and have some irritability, you have to decrease the pain for the patient. So sometimes post-operative patient, if you find the patient is tachycardic, it's because if you make it by exclusion, without only pain makes him tachycardic, and so on. Delirium has no impact on the length of hospital stay. No, if the patient is still delirium, he will stay in hospital. A regional anesthetic rather than general anesthetic is more likely to contribute to post-operative cognitive impairment. For sure, no. As regional anesthesia can make more problems than general. If you give spinal anesthesia or any regional anesthesia for the arm or for lower limb, no, general anesthesia has more effect. Visual hallucination are not a feature of delirium. No, visual hallucination can happen with delirium. Whatever, this question, I tell you, some questions have no other related questions, and it will not mix or make you confused with other questions. This question came like this, and I didn't see it for a long time in recalls. Okay, keep it. Use of benzodiazepines pre-operatively, uses long-term post-operative. By the way, in the exam, many scenarios, especially pharma questions, are repeated as it is. And this is one I didn't see it for many years, maybe up to recall 2016 means 4 years or 3 years and 3 exams, more than 12 exams before, and before even I didn't see this question. Okay.
Okay, thank you.
Next question, Dr. Baida.
Okay, 75-year-old man is admitted to the intensive care unit Following a laparotomy, he has a central line, pulmonary artery catheter, and arterial line inserted. The following results are obtained. Pulmonary artery occlusion pressure is high, cardiac output is low, systemic vascular resistance is high. How may these findings is best interpreted? Before look, we have pulmonary artery occlusion pressure is high, and with the low cardiac output and systemic vascular resistance is high. So it comes with hypovolemia or is normal, neurogenic shock, septic shock, and cardiogenic shock. The systemic vascular resistance is high, which occurs mostly as I think in cardiogenic shock. Okay, but the cardiac and the hypovolemia, but the cardiac output is low. Okay, so it comes with hypovolemia. And no.
Pulmonary artery occlusion pressure
pulmonary artery occlusion pressure is very high, so it's cardiogenic shock.
Cardiogenic shock. Cardiogenic shock. Again, we explain because many questions about this, how to interpret this question or a question with pulmonary occlusion, artery occlusion pressure, and cardiac output and systemic vascular resistance. You can start by any one and go by exclusion by the other. Let's start with systemic vascular resistance as we start in many questions. When systemic vascular resistance will be high and hypovolemia, yes.
And cardiogenic.
Normal, no. Neurogenic shock, vasodilatation, septic shock, decreased systemic vascular resistance, cardiogenic shock, yes. Yes. Okay, so we have A and D. Let's go for other parameters. Cardiac output is low. Okay, and hypovolemia sometimes, but there is tachycardia, but cardiac output is low because there is loss of blood or loss of fluids. So if doesn't give me the perfect answer, let's go for the pulmonary artery occlusion pressure. Pulmonary artery occlusion pressure. Pulmonary artery occlusion pressure measures the pressure
left
in
side
the
of the heart.
Right atrium.
Right atrium.
Right atrium. Right left atrium.
Left
Yes.
atrium. Right
Left
central
atrium.
venous pressure.
Sorry.
The right side
Left
is
atrium.
by JVP.
Yes, exactly. So left atrium. Yes.
Okay.
It is left atrium. Yes, I'm telling right.
Yes, the left.
Or right atrium.
No, it's left because the
Left atrium. Okay. When it is high.
What?
When it is high.
Okay.
When the pulmonary artery occlusion pressure is high. Pulmonary artery can't push blood to the lungs. Can't push blood to the lungs because the heart is not working, or the heart is working slowly,
the heart
or there is failure in the pump. There is a weak pump in the heart, so there is congestion of blood in the lungs. You have the idea? You get the idea?
No.
Cardiogenic shock. The heart is not pumping the blood, so blood is coming but is not pumping, so it is congested in the lungs, and that's what causes some pulmonary edema, pulmonary congestion, and so the pulmonary artery occlusion pressure will be high. Cardiac output is low, yes. Systemic vascular resistance is high, yes. Okay, but if he told you the pulmonary artery occlusion pressure is low, what will you go for? Hypovolemia. Okay.
Okay.
Is it clear?
Yes.
Okay, I'll share you on the group after finish. I think I finished, I sent it last time about the systemic vascular resistance, cardiac output, and heart rate, and pulmonary artery occlusion pressure. Okay.
Okay.
This is a good table to differentiate between hypovolemia, neurogenic shock, septic shock, and the cardiogenic shock. You have to, by your mind, again, here is the pulmonary artery occlusion pressure is indirect pressure of the left atrial pressure. Yes? Okay, we can read it together. Anyone can read. Okay, Dr. Ada, you can read it. Or anyone can read. Who's Dr. Baida? You can read it.
Okay. The pulmonary artery occlusion pressure is an indirect measure of left atrial pressure and thus filling pressure of the left heart. The low resistance within the pulmonary venous system allow this useful measurement to be made. The most accurate trace is made by inflating the balloon and the catheter tip and floating it so that occludes the vessel. If it is not possible to occlude the vessel in this way, then the measurement gained will be the pulmonary artery and diastolic pressure.
Okay, forget about the process. Okay, so we are measuring the left atrial pressure. Okay. So when the pulmonary artery occlusion pressure is
it will be normal if the pressure between 8 and 12 millimeter mercury. It's low,
exactly,
less than 5 millimeter mercury, and is indicative of hypovolemia. Low with pulmonary edema, less than 5, which is indicate adult respiratory distress syndrome. High, more than 18.
I don't like this point, and I said about last time, because I have to differentiate between pulmonary edema and ARDS. There is difference in between, but we can consider it pulmonary edema, so it is no, ARDS, not pulmonary edema. It's completely different. Okay,
we said previously in the pulmonary edema, which is indicated by the pulmonary wedge pressure more than 80.
Exactly.
Okay, and adult respiratory distress syndrome not more than 80.
Exactly. That's why. Okay, keep it normal, low, and high. High above 18. This is overload. Okay. Overload can cause cardiac failure. No, there is no failure in the pump of the heart. So there is a overload volume in the lungs and causes this. So just put it, I don't want to confuse yourself with physiology, okay, and deep physiology, mitral stenosis. Dr. Fadi. Open your mic. Okay, so we have two options here. Okay, so we have two options here. If low, we go for hypovolemia. Okay, if high, we'll go for cardiogenic shock. Okay, don't confuse yourself. Start by any point and continue to exclude your answer by exclusion, or to find your answer by exclusion. I'll send you the table after I finish. Okay, next question. Dr. Taheri.
Yes, which statement is false about Betadine? It is 30 times more liposoluble than morphine, structurally similar to morphine. Betadine has a toxic metabolite, not Betadine, which is cleared by the kidney. Betadine is metabolized by the liver and can be given intramuscular, structurally similar to morphine.
Exactly. Also, we said that it's pharma question. These questions are repeated as it is. Okay. Structure of Betadine is completely different than morphine. And by the way, that's why sometimes we use it in patients who have severe biliary colic. Sometimes, so morphine is completely contraindicated because it increases the spasm of the sphincter of Oddi and the biliary spasm and biliary colic. But Pethidine, sometimes we use it in patients have severe pain till the analgesic, normal analgesic we give the patient like non-steroidal or other analgesic start to work. Sometimes we use it no problem. Pain management, this is a big station, part B, according to the WHO analgesic ladder and what to start and how to continue. No need to read all of this, just time consuming for part A. Okay, next question again. Dr. Rada.
Which of the following anesthetic agents is least likely to be associated with depression of myocardial contractility? Propofol, eternidate, sodium thiopentone, ether, none of the above. The least likely. Eternidate, because sodium thiopentone cause cardiac toxicity. I don't know about ether actually, but propofol is antiemetic, we said, and for prolonged sedation. But I think eternidate, it causes adrenal crisis, but no cardiac toxicity.
So, what do you think?
Eternidate.
Eternidate.
Mm-hmm.
Dr. Tal, the same. No, propofol. She said propofol. Dr. Mahbub, B. Dr. Fadi, A. Dr. Tal, B. Tomidate, like the same like Dr. Ghada. Dr. Sarah, B. Exactly. Most favorable cardiac safety. We have two, etomidate and sodium cypentate. Has reverse or different action in the heart. Sodium, as long as I remember, sodium cypentate has marked myocardial depression may happen. Okay.
Yes.
That's I think we spoke about this last time. Said propofol has a good antiemetic effect. Okay, ketamine has a good analgesic effect, and this is the most point they are talking about. Okay, and sodium cypentate marked myocardial depression. Okay, and etomidate has a favorable cardiac safety. Okay, so cypentate and etomidate both on the heart. This is myocardial depression. This is favorable cardiac safety. On the reverse, etomidate and propofol, this is have antiemetic effect. This induce vomiting. So it is good in sync and bad in sync. Okay.
Yes.
Strong analgesic effect, and this is the one we use for patient hemodynamic unstable. Sometimes we use it. This is sometimes we use it in accidents and patients with hemodynamic unstable. We use ketamine. Okay. Clear about this table. Again, propofol, antiemetic effect, while etomidate is vomiting. Post-operative vomiting is common. Okay. Go for cypentate, cypentane and etomidate. Cypentane makes myocardial depression. but etomidate has a favorable cardiac safety. Ketamine has a strong analgesic effect and can be used suitable for patients with hemodynamic and unstable. Clear about this?
Okay.
This the most points you will be asked about. Next question, Dr. Sarah.
Okay. A 23-year-old lady undergoes a total thyroidectomy for Graves' disease. 6 hours post-operatively, she develops respiratory stridor and develops a small hematoma in the neck. What is the most appropriate course of action? Perform critical thyroidectomy, reopen the neck wound, perform a percutaneous tracheostomy, reassure the patients and prescribe an anxiolytics, insert a nasopharyngeal airway. I'll go for reopen the neck wound. It could be hematoma, yeah.
So you choose?
Reopen the neck wound. The symptoms could be due to a hematoma, yeah.
Okay. So a patient, post-total thyroidectomy, whatever for what cause, 6 hours post-operatively, she develops a respiratory stridor and develops a small hematoma in the neck. What is the most favorable is reopen it. Okay. I will remind you with 3 or 4 scenarios we have discussed in head and neck, and I think also with endocrine surgery. Okay, go for the next few scenarios. Post-operative patient, post-thyroidectomy, and the patient is has dyspnea. Patient with a large retrosternal goiter for a long time, long standing, and he went for total thyroidectomy. Post-operatively, the patient is dyspneic and has difficult breathing. What's your suspected diagnosis here?
So the patient had total thyroidectomy, you meant?
Patient has long-standing retrosternal, large retrosternal goiter, and performed a total thyroidectomy, and post-operatively has dyspnea and difficult breathing.
It could be laryngeal. It could be laryngeal injury or something like that. Could be caused by the laryngeal nerves injury. Am I right?
No.
Okay, some people are saying laryngomalacia. I think it has to do with the injury of the laryngeal nerves.
No.
Oh.
When he tell you about laryngeal nerve, will be noticed mostly intraoperatively, but will be, and it will be immediately post-operatively, and he will not mention in the question about the large, long-standing retrosternal goiter, and he will not put in the answers recurrent laryngeal nerve. By the way, mostly he will not put, but he here is asking about the most common diagnosis or the most possible diagnosis. I think many Dr. Ghada, Dr. Ittihad, Dr. Osama, tracheomalacia.
Tracheomalacia, okay, all right.
So long-standing, large retrosternal goiter, post-operative tracheomalacia. Go for the next scenario. Here is, and he tells you, and you inspect the patient, and the wound is clean, and he will mention you went to the patient and looked to the patient, and the wound is clean. Okay, go for the next scenario. Patient, post-operative patient, immediately post-operative, and the patient is dyspneic and can't breathe. And you went to see the patient immediately, and you just expose the wound and find that the wound is clean. What is your provisional diagnosis or most common diagnosis here?
Some people are mentioning edema because the wound, in that case, the wound is clean, right?
Yes, difficult breathing and dyspnea immediately post-operative. And the
This
wound
was
is clean.
laryngeal injury. Laryngeal nerve injury, I think.
Laryngeal nerve injury, recurrent laryngeal nerve injury. Recurrent laryngeal nerve injury. This is a scenario. Okay. The last scenario, or the third scenario, patient post-operative thyroidectomy, and the patient has sudden dyspnea, difficult breathing. You went to the patient, to the ward, and you expose the wound, and you find a swelling at the surgical site. What's your provisional diagnosis?
Hematoma.
Hematoma. What's your management?
Reopen.
Okay, in this management, in part B, you have to say you will reopen the wound in bed and urgent transfer the patient to operative room. Open the wound in bed. Open the wound in bed. Remove the stitch in bed and urgent transfer the patient to operation, because this is most commonly sleep ligature for one of the blood supply of the thyroid, especially the superior thyroid, that makes this. Okay, the last scenario about this patient, post-operative, post-thyroidectomy, and the patient, you went to the, you have informed that the patient has some difficult breathing with convulsions and muscle spasm. You went to the patient and exposed the wound. You will find the wound is clean. What you expect?
Potassium is low. Hypocalcemia.
Hypocalcemia because of?
Because of the parathyroid hormones perhaps are removed too.
Because
parathyroid hormones removal.
Parathyroid. Okay.
Hormones, yeah.
Okay. Because
the
of
gland is removed. The parathyroid
even
gland.
removed or ischemic. Removed or ischemic.
Okay.
Because of the sexual ischemia. Okay. Iatrogenic injury.
Okay.
So the patient has iatrogenic, and I did see it many times. Patient post-operative, especially if there is hard or some adhesions or long-standing goiter, but normal goiter, not return. Sometimes from the section, you decrease the blood supply of the parathyroids, and parathyroids get some relative ischemia, and the patient go for hypocalcemia. And the patient go for hypocalcemia. What's your management here if the patient is a difficult breathing? Why difficult breathing here? Spasm of laryngeal muscle because of hypocalcemia. Stridor.
Okay, yeah.
Spasm of the intercostal muscles. Difficult breathing. Okay, what's your management here? And do you have this question before? Yes, can you tell me the full dose? Can you tell me the full dose?
10% of 10 mils of calcium gluconate.
Over?
10 mils of 10% calcium gluconate.
Okay, 10 ml of 10% calcium gluconate. 10
over 10 minutes.
10 ml 10 calcium gluconate over 10 minutes. Okay, this is the most common scenarios come about laryngeal nerve injury or post-thyroidectomy operation. Okay, you have thyroid in endocrine, you have thyroid in head and neck, and you have thyroid here in post-operative. Clear, or anything is not clear?
Everything is clear.
Clear. All scenarios are clear. Okay.
Thank you.
Welcome. Okay, next question. Please write down these collections. It will help you in your study. Okay. Next.
Okay.
Dr. Baida.
Okay. A 23-year-old man is undergoing an open inguinal hernia repair as day case procedure and is being given a sevoflurane. What is the best option for maintaining this airway during the procedure? Insertion of endotracheal tube, insertion of the nasotracheal tube, insertion of nasopharyngeal airway, insertion of the laryngeal mask, use guidal airway. As he have open inguinal hernia repair, so it maybe use endotracheal tube.
Okay.
Okay, but it is high up and not in interfere with the GI, so we can use insertion of laryngeal mask. I think it's laryngeal mask.
Okay. You know the picture of the laryngeal mask, yeah?
Yes.
Okay. So we don't. What about use of Goodall airway? No. Insertion of
I don't know what this is.
nasopharyngeal airway? No. I didn't see nasopharyngeal airway except in some maxillofacial fracture or mouse fracture. Insertion of nasotracheal? No.
It's far away.
Endotracheal tube. Okay. Your option will be endotracheal tube and laryngeal mask. Here, yes, the recent trends now in short operation, not taking long time. You can use laryngeal mask. Prefer laryngeal mask because to decrease the complications that the patient feel post-operative from endotracheal tube with irritation, some sort of dryness, mouth, cough, injury of trachea. Exactly. And we maybe about more than 80% of our operations now, short operations or up to minor or moderate operation, we do it with laryngeal. Sometimes even long operation, we do it with laryngeal mask. Okay.
Okay.
Don't go for details, please. Don't go for details. Details are not required. And this question I didn't see before for a long time in recalls. Next question, Dr. Teher. Who's there?
Who?
Yes, who's there? Dr. Teher.
Yes, which of the following is not a diagnostic criteria for brain death? No response to sound. No response to sound is the answer.
Yes, exactly. If no response to sound is one of the options for brain death, so all our kids will be killed. Yes?
Yes.
Okay, to keep the question put in your mind, it is not a diagnostic criteria of death, not a kind of patient come to you in the ER, he is not and he's not answering, so it is not a criteria of this, but no corneal reflex. The patient, this is others, or what you do for the patient to make sure that the patient is this about corneal reflex, oculovestibular reflex, no response to supraorbital pressure, no cough reflex, or bronchial stimulation. But no response to sound is not a criteria of brain death. Put in your mind and keep in your mind always when reading the question, look to not a or a diagnostic criteria or all except or all of this. I think means pharyngeal stimulation. Yes, not bronchial stimulation for sure, or laryngeal, maybe something like this. Yeah, maybe he wants to insert something in the bronchus, and if he not die, he will die for this. Yes, maybe laryngeal stimulation. Dr. Fadi is ER, and he is very very concise with us now. Okay. Next question. Doctor Ghada?
You
Anyone
are at
wants
the
to share also can raise hand. Anyone wants to? Now we have Dr. Ghada, Dr. Sarah, Dr. Baida, Dr. Ibtihal. Anyone wants to participate? Ibrahim, Dr. Ibrahim, welcome. Dr. Mahbub, okay. You'll take your turn after the fall because Dr. Ghada started. Okay. Then Dr. Ibrahim, then Dr. Mahbub. So Dr. Ghada, Dr. Sarah, Dr. Baida, Dr. Ibtihal, Dr. Ibrahim, Dr. Mahbub. Okay? Yeah, go.
You are at the cardiothoracic surgical registrar reviewing a patient referred for an aortic valve replacement. The 40-year-old man is being investigated for progressive breathlessness in previous respiratory clinic. The notes show he has smoked for the past 25 years. Pulmonary function tests reveal the following. FEV1 is 1.4 liter, FVC 1.7 liter, FEV1 to FVC 82%. What's the most likely explanation? Asthma, bronchiectasis, kyphoscoliosis, chronic obstructive pulmonary disease, laryngeal malignancy. So this ratio is more than 80%, so it is not an obstructive disease. This is for restrictive disease. Asthma and COPD, bronchiectasis, even malignancy, all of them are obstructive disease. So kyphoscoliosis is different. There's a restriction. So kyphoscoliosis may result in such a high percentage. So I think C is the correct answer.
Type C, so kyphoscoliosis. I think this is this question will be more clear or more easy after physiology, or if we studied after physiology. We have two exactly, as Dr. Ghada said, kyphoscoliosis. Okay, this question will be more easy if when we studied some physiology and said what is the difference. Dr. Ali Hilali, welcome. Difference between restrictive and obstructive pulmonary disease, and most common questions come with the FV, forced expiratory volume in 1 second over the forced expiratory forced capacity, the full forced volume capacity. Okay, here in restrictive we said both of them are decreased. Functional volume capacity and the forced expiratory volume in 1 second, both are decreased and give me a normal or a high ratio. So if it's normal or high, so it is restrictive disease. But in obstructive, the functional volume capacity is increased, okay, and at the same time, the forced expiratory volume in 1 second is decreased, okay. So the big ratio between both of them makes the ratio between the forced expiratory volume in 1 second and the functional volume capacity is less than 70, or sometimes 60, or sometimes 65, sometimes in a low 40 or 50 or something like this. This is obstructive pulmonary disease. Let's go for our question. Here is the FEV1 over the forced volume capacity, functional volume capacity is 82. So it is almost normal or higher than normal. So we go for an restrictive pulmonary disease. From all of these, only kyphoscoliosis is restrictive pulmonary disease. Okay, there is a nice video for physiology. 2 videos I shared about the capacity or the lung volumes. Everyone is about 15 or 20 minutes, and they're very informative. Go for them after the. I hope you did it before, because I think we have one question before. He'll tell you everything about the respiratory volumes, and then you have to see it first about the respiratory volume to know the difference between the volume and the capacity and the respiratory parameters, and then go for the restrictive and obstructive pulmonary disease to know what is the difference between forced expiratory volume in 1 second over functional volume capacity, and how to interpret this question. Okay, it's well illustrated in these 2 videos. This is the difference, and this is by the way, you can use this table also, but you have to understand first what is these parameters and what this abbreviation means. Then you can go for, if you understand, you will solve all the question without just putting this in your mind like this. So asthma, COPD, bronchiectasis, bronchiolitis obliterans, all this is obstructive, but pulmonary fibrosis, asbestosis, sarcoidosis, acute respiratory distress syndrome, or infant or kyphoscoliosis, or neuromuscular disorders, all of these can cause restrictive lung disease. Most common one is the kyphoscoliosis and neuromuscular disorder, by the way. Sometimes pulmonary fibrosis is one of the choices, by the way. Next question, Dr. Sarah.
Okay. Sorry, I was eating. Which of the following muscle relaxant is an agent that is degraded by the hydrolysis and may produce histamine release? I'll go for, when you have atrocomium, pancuronium, curare, suxamethonium, and bacuronium. I'll go for atrocomium. Hello?
You choose A.
Atrocomium, yes. Mm-hmm.
Exactly. Pharma question, as I tell you. You have 2 main tables here in post-operative. One is about the muscle relaxant, and one about the anesthetics. Okay, mm-hmm. This is one of the muscle relaxant we use as induction for anesthesia before you intubate the patient. Okay, no need for all this information. Okay, we said the most important information is the saxamethonium is depolarizing neuromuscular. All others are non-depolarizing muscle relaxant. Okay, this is the most important, by the way. Saxamethonium is the most common one coming in the exam. Okay. Mm-hmm. Saxamethonium depolarizing muscle. This is the only one depolarizing. Saxamethonium produces twitches in the face and some convulsions. Mm-hmm. Okay. And saxamethonium causes hyperkalemia because of the muscle twitches introduced by it. Also, one of the main causes of malignant hyperthermia, and this is maybe one every 1 or 2 million per person. Not, I think here is writing very little ratio, but really in our friends for anesthesia side, you can say it 1 in million patients. The last thing is the patient with saxamethonium can suffer from delayed recovery post-operative, and they can stay for 6 to 8 hours or more, and you may need to intubate the patient till hydrolysis of the saxamethonium happen, because this patient has a deficiency in cholinesterase acetylcholine esterase enzyme, hydrolase enzyme, or catalase enzyme. The most important of all of this, succinylsonium, is if you go for the exam and you have a question and you can't reach to a question about this, most common questions, about 80 to 90% come about succinylsonium. Go for succinylsonium. Succinylsonium is one of the most common used muscle relaxants in our hospitals, by the way, and most your friends in anesthesia use it, but it has this one. This is the only depolarizing, hyperkalemia, twitches, malignant hyperthermia, delayed recovery. Okay?
Okay.
Clear about succinylsonium? Others, sporadic questions, you will not find this, like the last question about histamine release. And reverse the pineostigmine, by the way. Okay. Next question, Dr. Baida.
A 78-year-old man presents with a ruptured aortic aneurysm. This is repaired, but the operation is difficult as it has a juxta-renal location. Suprarenal cross-clamp is applied. Post-operatively, he is found to be oliguric and acute renal failure is suspected. Which of the following statements relating to acute post-operative renal failure are untrue? Intravenous dopamine does not prevent acute renal failure. It is more common after emergency surgery. Use excessive amount of intravenous fluid may lead to falsely normal serum creatinine measurements. Vasopressor drugs have a strong renoprotective effect. It is minimized by normalization of hemodynamic status. The first of all, intravenous dopamine does not prevent acute renal failure is false. I think it prevents. No, it's this is the false. And common after surgery, this is true. And use excessive amount of intravenous fluid may lead to falsely normal serum creatinine measurement. This is true. Yes. Vasopressor drug have strong renoprotective effects. I don't know. Strong renoprotective effect. No, this is untrue. I think the vasopressor.
Exactly.
Okay. Because vasoconstriction and affect the renal system.
Will affect the renal blood flow and
yes, by vasoconstriction.
Glomerular filtration rate. Okay. But intravenous dopamine can prevent, yes. Can you remember anyone about the doses of dopamine? We said that dopamine is dose dependent, and in low doses, it acts on D1 and D2 receptors, and these receptors are in the afferent arterioles of the kidney of the glomeruli, and this causes dilatation and increase the glomerular filtration rate. Okay, and in moderate doses, it acts on alpha, on beta and alpha receptors, and in high doses, acts on beta receptors to increase the heart rate.
Okay.
I sent it last time. Dopamine is dose dependent, and this is very important point you have to mention in part B. Dopamine is dose dependent. Okay, next question.
Okay, which of the following is most suggestive? Malnutrition. Hyperlipidemia, BMI of 22 kg per square meter, and unintentional weight loss of more than 5% over 3 to 6 months. BMI of 18.5 kg over square meter. Reduced skin turgor, unintentional weight loss of more than 10% over 3 to 6 months in a 60 kilogram female who is
1.6
meter tall. Okay. Unintentional weight loss of more than 10% of over 3 to 6 months in female who is 1.6 meter tall. BMI of 22 kilogram is not a malnutrition. Hypoalbuminemia is not an indication or description of malnutrition. Reduced skin turgor is for dehydration, and BMI of 18.5 only is not a malnutrition.
What is the normal range of BMI?
I think that's
not for Egyptian, not for Egyptian, not for Arabian or Egyptian people. What is the normal range of BMI?
18 to 24.5.
18 to 24.9.
Okay, the normal range of people about from 20 to 25. Just keep it in your mind, because if you're going to work in bariatric, so 25 is 24, 23, 22, 25. This is the normal person you can find away from Arabian or Egyptian people. Okay. So, but here up to 18.5, but this is a very same person, but it is up till now up to normal. So if patient is malnourished, hypoalbuminemia is an indicator of malnourishment? No, most hepatic patients have malnourishment, have a hypoalbuminemia, but they are not malnourished. Okay. BMI of 22 and unintentional weight loss more than 5% over 3 to 6 months? No, but this is an indicator of just losing weight and something like this, but not malnourishment. BMI of 18.5? No. If less than, maybe. Less than BMI of 18 or 18.5? Yes. Reduced skin turgor? No. This is some sort of dehydration. Unintentional weight loss over more than 10% over 3 to 6 months in a person with BMI of 60 over 1.6 meter tall. By the way, you need to calculate this in exam and to be a little bit difficult. Okay, because this person 1.6, 0.6, 2.56, 23. This person has a 23.4 BMI. So if he is losing more than 10% in a normal person, this is malnutrition. If more than 10% in a normal BMI person, or more than 5% in a malnourished person, less than 20. If more than 20, up to 10%, more than 10%, he is considered malnourished. Okay, but less than 20, I think we have it here. Yes, exactly here. I'm just talking about it. Okay, this patient is malnourished patient. This is the malnourished patient. Sorry, this patient less than 18.5, unintentional weight loss more than 10% over 3 to 6 months in a normal BMI patient. But if the patient is less than 20, unintentional weight loss more than 5% over 3 to 6 months. Okay. Clear? Hello, I lost. Okay, Just anyone, just answer me. Okay, Dr. Ibtal.
Yes, it's clear.
You have only maybe I think I faced one question in BMI or about bariatric, about malnourishment in previous exams. Okay, so we'll start with Dr. Ibrahim, then Dr. Mahbub, then Dr. Ali. Dr. Ibrahim.
Yes, hello, Dr. Rami.
Dr. Ibrahim. Hello, we want to run because this
Okay.
question should take more than 1 hour and we almost about 1 hour now. Okay, go.
A 52-year-old man is recovering following an elective right hemicolectomy for carcinoma of the cecum. His surgery is uncomplicated. When should oral intake resume? Only once bowels have been opened to stool. Only once the patient has passed flatus. Between 24 and 48 hours of surgery. More than 48 hours after surgery. Within 24 hours of surgery. I'm confused between C and E, but I think I choose E because the advanced recovery programs.
Exactly. Advanced recovery programs now, within 24 hours, you give the patient, no problem. Or if the patient before the 24 hours start to pass flatus, but not immediately after the operation because sometimes there's some collected gas. Okay, you can give the patient to start oral intake. What is the idea before they can start the patient pass flatus? But your normal GIT produce fluids normally if you didn't eat. So stomach, esophagus, jejunum, ileum, daily production of some fluids. So already some fluids are inside the GIT tract. So you are not afraid from oral intake because if it is fistula, it will happen from the normal GIT secretions. So they start to give the patient within 24 hours, it is a time for any secretion in the stomach, start to move to reach the anastomotic site. It's within the 24 hours, so why not I give the patient oral fluid and it will help him in the recovery, fast recovery problem or enhanced recovery problem. Okay, within 24 hours of surgery, you can give the patient. Don't wait till the patient open bowel to stool. The patient can stay 1 week. Once the patient has passed the flatus, no, sometimes the patient in OR during transfer, you find the patient post flatus, and this is just false impression about bowel movement. 24 hours and 48 hours, no, it's long time, and more than 48 hours, the patient will be dehydrated. Next question, Dr. Mahbub. Dr. Mahbub. Dr. Mahbub Al-Hassan. Dr. Ali, تفضل.
Yes. With which of the following blood products is iatrogenic septicemia with a gram-positive organism most likely? We have cryoprecipitate, platelet, packed red blood cell, factor 8 concentrate, factor 9 concentrate. Yeah, I'm going with platelet.
Okay, why?
Yeah, or I have another suggestion, maybe packed red cell.
Packed red cell.
Yeah, either platelet or packed red cell. But mostly I'm going with platelet, I think.
Why? Do you know the cause?
But why? Because I think maybe the platelet have short life span and it's can
Another cause. Yes. Can read the your
Yeah,
comments.
we keep it with the room temperature, so it's good media for
Exactly.
bacteria. Yeah.
Exactly. Platelets is the most common blood product to cause infection. Okay.
Yes.
Platelets, keep this point in your mind, is the most common blood product to cause infection, but it is most commonly cause infection. Okay. There is a difference between, I tell you, platelets is the most common one of the blood products that cause infection because it is in room temperature. But I can't tell someone that don't give platelets because it is frequently or very common to have infection. No, it is the most common one of the blood products to have infection. Maybe all blood products have 0.5% and it has 0.7%. But normally blood products are clear and they are not causing infection. Okay. Clear?
Yes, clear. Thank you.
Yeah.
Okay. Dr. Mahbub, are you back? Okay. No. Okay. Dr. Ghada again.
Which of the following is a recognized feature of ketamine when used as anesthetic agent? Malignant hyperpyrexia, adrenal suppression, myocardial depression, dissociative anesthesia, marked respiratory depression. Malignant hyperpyrexia is for 6-newtonium, adrenal suppression for etomidate, myocardial depression for sodium thiopental, dissociative anesthesia is for ketamine, and respiratory depression is for propofol. So D, dissociative anesthesia.
Exactly. So by practice, we can know common questions we ask about. As you said, malignant hyperthermia, we said about succinylsodium, adrenal suppression, we said about etomidate, myocardial depression, about which one?
Sodium thiopental causes
Sodium
myocardial
thiopentate.
depression.
Sodium thiopentate, and respiratory depression with
Propofol.
propofol. Okay. Next question. Dr. Sarah.
Okay. A 45-year-old lady with cirrhosis of the liver is recovering following an emergency paraumbilical hernia repair. She has been slow to resume oral intake and has been receiving regular boluses of normal saline for oliguria. Which of the following intravenous fluid should be considered? 5% dextrose with 20 millimole of KCl, 1.8% saline, human albumin solution 4.5%, 10% dextrose with 20 mil kgs KCl, and then 0.545% sodium chloride. 10% dextrose with 20 millimole of KCl. COVID emergency public and precious people. Then how about the albumin? The human albumin solution of 4.5%.
Exactly, she is a
Because it has to do with
patient.
liver cirrhosis. Yeah, liver cirrhosis patient. Yeah.
Liver cirrhosis, and she has a slow and resuming oral intake. By the way, sometimes they give preoperative or post-operative, gives the patient of liver cirrhosis human albumin, and sometimes give him fresh frozen plasma to increase the rate of healing and make the patient improve as soon as possible. But human albumin is put it in consideration in patient with surgery. D, in patient with surgery for rapid recovery and rapid healing. Okay.
Okay.
Okay. Dr. Baida.
Okay. 73-year-old man undergoes a right below knee amputation for end-stage peripheral vascular disease. He is reviewed in the clinic 8 weeks post-operatively and complains of persistent burning discomfort over the amputation site stump. On examination, his wound has healed and the proximal pulse have a biphasic signal on Doppler ultrasound. What is the most appropriate management? As it's neurological pain, so we think about the treatment for the neurological type of comments, amitriptyline in the first line. Okay, and there's another as I remember, if patient another we can use I forget
gabapentin.
Another drug.
Gabapentin. Is it gabapentin?
Pregabalin.
Pregabalin or gabapentin?
Pregabalin. Okay. If the patient have hypertension, we can use this.
We can't use this in patient with orthostatic hypotension.
Okay.
Orthostatic hypotension or patient with hypertension, we can't use amitriptyline, but we can use pregabalin. So this is a neuropathic pain. This is a neuropathic pain. So
okay.
Sorry, this is a neuropathic pain, and in neuropathic pain we use amitriptyline if the patient has orthostatic hypertension. The patient or hypertension, we can use pregabalin. And can you remember others for diabetic pain? What we use? Diabetic neuropathy.
Duloxetine.
I can't remember.
Who answered? Write in chat. Diabetic neuropathy. Duloxetine. Okay. Duloxetine. Okay. In trigeminal neuralgia.
Gabapentin.
Trigeminal neuralgia. Carbamazepine. Exactly. So, in neurogenic pain, like patient have some neuroma or something like this, we prefer to take amitriptyline or pregabalin, except for neuropathic pain. For diabetic neuropathy, we use duloxetine. Okay. And in trigeminal neuralgia, we use carbamazepine. Okay. In metastatic pain in the spine, what we use? Metastatic pain in the spine. Start with analgesic ladder, NSAIDs, morphine, but mostly they respond to radiotherapy. Most patients respond to radiotherapy. Dr. Abu Yazid, yes. Patient with metastatic spine pain, metastatic pain mostly respond to radiotherapy. I think we have here. Yes. Triptyline. Management, topical education, localized. This is for neuropathic pain after pregable. Specific conditions for neuropathic pain is carbamazepine, we use it for trigeminal neuralgia, and duloxetine, we use it for diabetic neuropathy. This is very common questions, by the way. 3 very common questions, by the way. Okay.
Yes, it was my question about trigeminal neuralgia before.
Yes, yes.
Yes.
This is the second time we repeated, by the way, after we discussed it. Yeah.
Yes,
As
I
an
remember.
exception.
Yes, thank you.
Thank you. Who's next, doctor? Who's next? Dr. Tal or Dr. Ibrahim? Who's last one?
Yes. I'm the last one.
Dr. Ibtihal?
Yes, okay.
No. Dr. Ibtihal?
Yes.
Okay. Okay, Dr. Ibtihal, go.
A homeless 42 years old male had an emergency inguinal hernia repair 24 hours previously. He has a BMI of 15. His electrolytes are normal. What's the best initial feeding regimen? Give 10 calorie per kilogram per day initially. Oral thiamine 200 to 300 milligram per day. Vitamin B co-strong 1 twice daily, and supplements. I think this is the answer. No. 1 second.
No. Yes, that's right. I'm just looking for a call. Okay.
Okay.
This is the patient is BMI is 15, so his electrolytes are normal. What is the best initial? This patient is BMI 15, so this patient is malnourished. What you give? You give him 10 kilocalorie per day initially, oral thiamine, vitamin B complex, TDS, and supplement. This question is not very common, by the way, in exam. And just know it like this. But I didn't see in any recalls 10 years ago. Okay, maybe in part B because you have the surgical nutrition, you have the complication of surgical nutrition, and you have to know about the refeeding syndrome and complications of refeeding syndrome. And here, what is he giving this patient is to protect against refeeding syndrome. So this patient is given slowly his food or his feeding formula together with thiamine and vitamin B complex to protect against refeeding syndrome. Okay, because if this patient you give a very high calorie, this patient may go for refeeding syndrome. Okay, not very common question. No, it like this. Clear. Most question, by the way, in recalls, you will have a change. You change your mind about common questions in the exam. No difficult questions will be, especially last 2-3 years. Most questions are on hands, and many questions that came once and has a very low rate of answering. It is removed from the same exam, by the way, and you can find your exam not 300. Exam high mark is sometimes 295, 96, and so on. But eMRCS is adding all new questions every year. And this question, I didn't see it for many years. Okay, next question, Dr. Ali.
Yes, 48-year-old man is recovering on high dependency unit following long and complex laparotomy. His preoperative medication include an ACE inhibitor for blood pressure control. For the past 2 hours, he has been oliguric with urine output of 10 ml per hour minus Yeah. What is the most appropriate immediate course of action? Stop the AC inhibitor, administer a fluid challenge, start an infusion of non-adrenaline, administer of intravenous furosemide, insert of Swann's Ganz catheter. Actually, I'm going with, I have two options. Stop AC inhibitor and administration of fluid challenge, but I'm going with fluid challenge because we have oliguria and we have grade 5 renal failure. It's I think 10 ml per hour, yeah. Yeah, it's a sign of renal failure. So I'm going with the fluid.
Fluid challenge. Here he wants to ask you about what you give in patient with oliguria post-operative. Okay, a big station in communication skills in part B. You are calling your consultant to inform him about a patient post-operative and started to have low urine output. Tell the patient has anuric or oliguria. What is the normal urine output for a patient? About?
It's 1 ml per kg per hour.
At least 0.5 ml per kg per hour. So this patient normally should have at least from 30 to 35 ml, okay?
Yeah.
This patient has 10 ml, so the patient has oliguria.
Yeah.
Okay. And oliguria, as a consultant on phone, this is a case of phone call communication. When you tell your consultant about the patient, he will ask you, what did you do for this patient?
Yeah.
Okay.
Yes.
What did you do for this patient? First, you can start immediately with what is called fluid challenge. Fluid challenge, you are giving the patient 250 ml of normal saline, bolus, as soon as possible, and wait for response, and you are allowed to repeat it 3 times.
Yeah.
And then start the patient to refer the patient to ITU and start to have to see if there is a problem, start doing your ultrasound, if the patient is hypovolemic, maybe the patient have bleeding, and you start your investigation. But first you have to do fluid challenge, which is giving the patient 250 ml of normal saline bolus and repeat it for 3 times and waiting for response.
And we have also to stop the AC inhibitor because, you know, this is antihypertensive drug, and
yes,
it's also cause hyperkalemia, and it's electrolyte disturbances, and it causes renal failure also.
Exactly. But here is the most appropriate is to give the patient a fluid challenge. Put in your mind fluid. Put in your mind two expressions we'll use in part B. What is the difference between fluid channel and fluid resuscitation? Okay. Fluid challenge and resuscitation. Fluid challenge, it is given for patient oliguria. Fluid resuscitation, you give it for hypovolemic patient in trauma or in accidents. And patient coming and the patient is shocked, you give what's called fluid resuscitation. And this has a formula, and this has a formula in giving how to give it. Okay. These expressions are very important part B, by the way. Next question, Dr. Mahgoub or Dr. Ibrahim. Still with Dr. Ibrahim and Dr. Mahgoub. Dr. Mahgoub, okay.
Okay. 50-year-old man has arterial blood gas sample taken, and the following results are obtained. He is breathing room air. pH is 7.2, PO is 7.5, HCO3 is 22, BCO2 is 8, Cl is 10. Which of the condition listed below is most likely to account for this finding? Okay, his pH is low acidic pH. His bicarb is normal, so it is not metabolic, it is respiratory. Or
Okay.
and
Analyze the data you have. What about the pH?
pH is low. This is means it is acidic.
Okay, pH is acidic. Okay.
Uh,
O2 pressure.
I didn't know about O2. It is normal, I think.
That's hypoxia.
No, hypoxic. Okay, in exam, in exam, he will make like this for you. He'll give you a table of 2 or 3 channels and he will write this for you.
You mean in exam they give the normal value?
They will give you the normal value. Most exams now give you the normal value.
Mm-hmm.
Okay, in exam, he will give you the normal value. And then chloride. According to this normal value, what do you expect this patient?
This is more easier like this. Okay, this is acidosis and hypoxia means this is some respiratory problem. Okay, bicarb is normal and his BCO2 is high. I think this should be an respiratory, one of this type of respiratory failure.
So this respiratory acidosis, yes? Okay.
Oh, no acidosis here. Just type 1 respiratory failure or
Okay,
type 2?
so no respiratory acidosis, because if you put respiratory acidosis, you will have 2 answers right.
Yes.
So we are between. We have 3 answers wrong. All metabolic answers are wrong. Yes?
Just respiratory.
So we are between. He wants to test
and
your knowledge about respiratory failure type 1 and type 2. And this is what? Which one?
I didn't know, but I think it is 2. I will say 2.
You have 2 parameters. Okay, it's very easy to remember. In respiratory failure type 1, you have only 1 parameter abnormal, which is hypoxia. In type 2, you have hypoxia, hypercapnia. You have 2 parameters.
Yes.
Abnormal.
Okay. So the answer is E, type 2 respiratory failure.
So the answer is
E. Type 2 respiratory failure. Yes.
Okay, type 2 respiratory failure. It's very easy to approach. But I want you really about ABG. Keep it by heart. Don't look for normal values. Keep it by heart. It will save time for you. You have about 15 to 20 questions in exam about respiratory failure and about metabolic and about acid-base balance and about ABG. Put it by heart. Keep it by heart. Normal values in milli equivalent and millimeter mercury. And I shared a table last time. Keep it by heart. Really, you will save time in the exam. You still have time in the exam to think about it is metabolic or respiratory, and is it compensated or not compensated. Don't go for the normal value in each time. Keep it in your mind like your name. Like the Galaxocoma scale, by your name.
Okay.
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 pH C 7.35, 7.34, 45. PO2 from 80 to 100% millimeter mercury, or it is 10 to 13 by what's called, you make me forget. Okay, 10 to 13 kilopascal, HCO3 is 22 to 26, so it is normal. CO2 pressure is from 4.6 to 6 kilopascal, or 6.1 sometimes in exam, but put it in 4.6 to 6, it will be easy for you, 6.1, okay? And that's all, and this is the parameters will come for you in the exam, okay?
Okay.
Save time for other questions, please. Any parameters I forget or any tables you don't know, send me in the group after the session to send it for you, because I forget everything after the session. Okay, any table I mentioned to send it and I didn't send, or you don't know, or you didn't see before, tell me and I can send it again. Okay, next question. Dr. Ibrahim. Where's Dr. Ibrahim? We lost Dr. Ibrahim. Okay. Dr. Ghada again.
A 40-year-old man is due to undergo laparotomy for small bowel obstruction. What's the best option for maintaining his airway? Insertion of a cuffed endotracheal tube, insertion of uncuffed endotracheal tube, insertion of laryngeal mask, insertion of nasopharyngeal airway, percutaneous tracheostomy. It's an endotracheal tube at the first place, but cuffed or uncuffed, I'm a little confused between either cuffed endotracheal tube or uncuffed endotracheal tube, because one is used in pediatric, one used for adult. Maybe
most
cuffed.
pediatric endotracheal tubes are uncuffed.
Uncuffed, right? Yes.
Most pediatric are uncuffed.
It is uncuffed.
And most, yes. No,
so
most
the
pediatric is uncuffed. Most
yes,
adult
and
are cuffed.
Adult, it's the opposite, so it's the cuffed one.
Cuffed for you. Most patients you see in operations, you put the endotracheal tube, they inflate the cuff.
Yes.
The cuff, okay. But in pediatric,
without cuff.
Most
pediatric.
of them without cuff. Most of them without cuff. Maybe starting from 4.5 inch or 5, you can find it without cuff. More than this, 5, 5.5, and 6, and 6.5, and 7, up to 8, all are cuffed endotracheal tubes.
Yes.
The same, uncuffed endotracheal tubes are used for children
to
risk of
reduce the risk
endotracheal injury.
of tracheal injury.
Yes, exactly. Next question. Who's there? Dr. Sarah.
Okay. 45-year-old man is involved in a polytrauma and requires a massive transfusion of black red cells and fresh frozen plasma. 3 hours later, he developed marked hypoxia and his CVP is noted to be 10 mm mercury. The chest X-ray shows bilateral diffuse pulmonary infiltrates. What is the most likely diagnosis? Pulmonary embolism, myocardial stenting, myocardial infarct, fluid overload, transfusion associated lung injury. I'm going for transfusion associated lung injury because of like the X-ray that shows the pulmonary infiltrates bilateral with the raised GVP.
GVP is 10. CVP is 10. CVP is 10. Chest X-ray show bilateral diffuse pulmonary infiltrates. So this is transfusion associated.
So transfusion associated lung injury is the answer.
Exactly.
Okay.
Next question. Dr. Baida.
A 52 year-old man undergoes a laparotomy for perforated bowel after a colonoscopy. 2 days after surgery, the nursing staff report this is a pink serous fluid discharging from the wound. What is the next most appropriate management step? Okay, IV antibiotic for wound infection. No further management. Examine the wound for separation of the rectus fascia. Insert a drain into the wound. A CT abdomen. As it's acute, within 2 days, we can examine the wound for separation of the rectus fascia.
What you doubt?
I think so. And maybe there is a leak or
What you doubt? Why you will examine the wound separation?
Okay, because maybe there is dehiscence, wound dehiscence, which occur.
Exactly. I just want to hear this from you. Serous sanguineous fluid, pink serous fluid, early post-operative, especially in the second day. You doubt abdominal wall dehiscence. Okay?
Okay. Okay.
So you will put your hand on the wound, okay, and try to feel the rectus sheath. If you feel dehiscence of the rectus sheath, so it is an abdominal wall dehiscence wound.
Okay.
This is in practice, by the way. Put it in your mind. If you find a patient during your round and you find the patient serous sanguineous fluid coming or serous pink fluid coming from the wound, first doubt is the is about the abdominal dehiscence. Make sure this is abdominal dehiscence first, so you can use a belt, hold the patient, try to manage the patient so early. Okay, next question.
Okay, thank you.
Yeah, this for me.
I think Dr. Tahel, I think.
Okay.
Dr. Tahel is here or lost? She's lost. Dr. Ali.
Yeah. Okay.
Dr. Ibrahim also is lost. So two lost after you, Dr. Ali, before you.
Okay.
Okay, we are losing many. Okay.
Okay. 63-year-old man undergoes subtotal colectomy and iatrogenic injury to both ureters sustained. He develops renal failure and his serum potassium is found to be elevated at 6.9 millimole per liter. An ECG is performed. What is the most likely finding? Increased PR interval, prominent U wave, neurocurus complexes, peak T wave, and low ST segment. I'm going with peaked T wave because in hyperkalemia we have hypertented T wave.
T wave, peak T wave. So you choose D.
Yeah.
Yes, but if it is hypokalemia?
Hypokalemia, I think it is flat or inverted T wave. I'm not sure actually.
Yes, U wave. Hypo. Put in your. This is what it shows. Which come in the options. And hypokalemia, hypo U wave. Hypo U wave. Prominent U wave. Prominent U wave. And hyperkalemia, peaked or tall P wave.
Yes.
Okay. Plus sometimes widening QRS, but this is we are talking about the T wave and the U wave, which is by the way, it is shallow to T wave, but it's after it comes a prominent U wave. So in hypokalemia is characterized by U wave. It's the most important. If it comes, a T wave will be low or a little low, not flat, but in hyperkalemia, the T wave is peaked or tall T wave.
Yeah.
Next question, Dr. Argob.
56-year-old man with chronic schizophrenia undergoes cholecystectomy. He received metoclopramide for post-operative nausea. 20 minutes later, he becomes agitated and develops marked oculogyric crisis and oromandibular dystonia. Which of the following drugs may best alleviate his symptoms? This patient, this is extrabilateral symptom due to metoclopramide.
Pure pharma question. What is the antidote for the metoclopramide here? Patient, or how to treat an oculogyric crisis or extrapyramidal syndrome for this patient? Pure pharma question. Okay, don't think about thinking about some. No, not B, not C, Dr. Ali. Because A, procyclidine. This question, by the way, all pharma question in my exam came like is. All pharma questions are repeated in the exam. Okay, so procyclidine.
So I just confused first because confused about. But what I know, we give the patient with Parkinson-like symptoms, like this extrapyramidal symptoms. We give either we give either antihistamine like alarmine or something like this, or we give lorazepam or diazepam, and we have two choices.
Mm-hmm.
But this is maybe all the story. I remember this is from old information.
Yes, maybe yes, but I can't remember exactly because even I don't like pharmacology since I was in college, so I don't like pharmacology. That's why I didn't go for pharmacy. Okay, pharmacy college. Okay, keep it like this. Patient oculogyric crisis, and you have to reverse his symptoms. You go for procyclidine.
Procyclidine, okay, procyclidine.
Okay, really, you have many questions for pharma. It will be more confusing if you go for more details. Next question. And post-operative is mostly pharma, yes. Yeah, who's going for this question? Dr. Ghada.
Which of the following? Okay. Which of the following anesthetic agent has the strongest analgesic effect? Sodium thiopental, ketamine, midazolam, etomidate, or none of the above? Strongest ketamine.
Exactly. I think it's easy now, yeah?
Yes.
And what is the other feature of ketamine?
Dissociative anesthesia and used for unstable conditions.
Okay, sodium thiopental. What is its main features?
Cardiac toxicity and causing vomiting.
Not it with the vomit. Keep it with cardiac toxicity. Etomide.
Etomide for causing adrenal suppression and vomiting. Yes.
Yes.
And
the cardiac.
It's the safest cardiac effect.
The safest cardiac. So safest cardiac. Adrenal suppression. Yes.
Etomidate.
And causes vomiting. Yeah.
Yes.
And which one is not causing vomiting, has a strong antiemetic effect?
The antiemetic propofol with respiratory depression.
Propofol. I think we started to know them, yeah? Propofol. The only question came about the antiemetic effect. Okay. Sodium thiopental, marked myocardial depression. Okay. And ketamine, we have many questions about it. Strong analgesic effect. Later myocardial depression, so we use it in hemodynamic unstable, and it causes dissociative anesthesia. The last one, etomide, has a reverse action about the propofol, about it causing some vomiting, but it has a reverse of sodium thiopentate about safest myocardial side effects and myocardial depression, the least one, the favorable agents. and causes may cause adrenal suppression. Is it easy about analgesics? I think by question we could collect it. Yeah.
Yes.
Okay. If you try to study the table many times like this, I think it will be easy forgettable. But with questions, it will be easy to remember. Okay. Next question. Dr. Sarah.
Okay. Which statement is true on enteral feeding? A PEG can only be used 12 hours after insertion. A motility agent is avoided for ITU patients with an esophageal tube. A regimen of 24 hours continuous feeding is recommended for DTU patients. It is associated with more hepatic synthetic disruptions than use of TPN. Enteral feeding is not possible if upper GI dysfunction. I'm not sure, but I will go for PEG can only be used 12 hours after insertion.
Why 12 hours after observe? Why you don't use it when you? Why you don't use it when you insert?
I think you cannot use PEG for more than 24 hours. I forgot the reason. I definitely forgot the reason.
Okay. Is motility agents is avoided in ITU patients with nasogastric tube? Okay. Is avoided patient with nasogastric tube? Why you give it? You don't give him motility agent? It is avoided? No, you can give him, no problem. A regimen.
Okay.
Okay. A regimen in 24-hour continuous feeding is recommended for ITU patient. Maybe. Okay. Maybe. Yes. You make a full regimen for him for eating. It is associated with more hepatic synthetic disruption than the use of TPN. Hepatic synthetic disruption, hepatic disarrangement happened in enteral feeding more than total parenteral feeding. No. TPN causes more hepatic dysfunction and the hepatic hepatic function disorganization, hepatic enzyme dysfunction. Enteral feeding is not possible in upper GI dysfunction. No, you can go for gastrostomy or jejunostomy and give feeding. Yes.
Okay.
Sometimes by exclusion, try to think about the question. If it is you find by exclusion is hard, so you have to know the question before or to get the answer. So motility agent you can use easy. You can use in patients with nasogastric tube, not to vomit. Sometimes they are giving something like Brim, something like Zofran and something like this for patient not to vomit because of the nasogastric tube. Associated TPN is more associated with hepatic enzyme dearrangement, and enteral feeding can be given for a patient with upper GI dysfunction. Yes, can given to a patient, but can't be given to a patient with lower GI dysfunction, like some intestinal or colonic dysfunction. You can't give him an enteral feeding. Okay. Take a picture with your mind for the question. Next question, Doctor.
Okay. Which of the following does not need monitoring during home parenteral nutrition support? Folate level, zinc level, vitamin D, thyroid function, bone densitometry. Okay. Folate, zinc, vitamin D, all necessary for parenteral nutrition. Also bone densitometry for calcium, but thyroid function, I doubt. So I choose thyroid.
Exactly. Yes, this is some protocols to do the bone density. I think bone density, you make it once per year or once every 2 years. But folate levels, zinc levels, vitamin D levels, one of the weekly and monthly mineral you have to follow up for a patient with parenteral nutrition at home. But this table you should have an idea in part B, by the way. You'll have it, but it is not frequently asked, but sometimes they ask it in difficult centers like UK and in new stations. Every 2-3 weeks, every 2 to 4 weeks, you have zinc, folate, or vitamin B12 and curium, I think, copper levels. Every 3 to 6 months, ferritin level and magnesium and iron. Every 6 months, vitamin D, bone density on a starting home and nutrition, and every 2 years. Bone density, we make it twice per year. BMI, you make it start, and weight, the patient should be weighed daily, then weekly. BMI also at the start of treatment and then monthly, and so on. This will be how you have a table for this in part B, by the way. So you have to know some information about it. Okay, next question. Who's turn? Who's turn? Turari, go.
Yeah, maybe. Yeah. Okay. Which of the following is not typically included in total parenteral nutritional state solution? Fiber, lipid, potassium, glucose, magnesium. I think fiber, maybe.
Yes. How about total parenteral nutrition? Fiber, no. Lipids, yes. Potassium, yes. Glucose, yes. Magnesium, yes.
Yeah.
Fiber is not included in the regimen
Yes.
of
Yeah.
total parenteral nutrition. Next question, Dr. Mahbub.
A 28-year-old man with poorly controlled Crohn's disease is nutritionally compromised. The decision is made to start total parenteral nutrition via which of the following route should it be best administered? Internal jugular vein via central venous catheter, internal carotid artery, cephalic vein via peripheral cannula, basilic vein via peripheral cannula, common femoral vein via central venous catheter. It is best to be given through central line, so internal jugular vein via central venous catheter, A.
Exactly. We don't give it in the internal carotid artery, and we don't use small veins like the cephalic and basilic or the common femoral distal veins. Only total parenteral nutrition is given by a central venous catheter through the internal jugular vein. Sometimes the subclavian vein, by the way, also. Okay.
Okay.
Next question, Dr. Ghada again.
Which of the following statements relating to the use of a human albumin solution is false? When administered in the perioperative period, it doesn't increase the length of stay in hospital compared with the crystalloid solutions. Concentrated solution may produce diuresis in patients with liver failure. It may restore plasma volume in cases of sodium and water overload. It may be associated with the risk of acquiring new variant Creutzfeldt-Jakob disease. Hepatitis C remains a concern when large volumes are infused. Okay, the false and the first option is true, and it's used for liver failure. So the second one, it's true. Restore plasma volume in case of sodium and water overloads. Either D or E. I think D. Something about this disease. I
Okay.
don't know.
Maybe
Because-
associated with risk
or
of acquiring
hepatitis.
new variant. Of,
Either
if you find
hepatitis.
some new expression in the exam, forget about this answer. By the way, sometimes it is
Okay. Something weird.
this is the most common. By the way, I'm not talking about absolute ideas, but sometimes if he mentioned a very strange syndrome or a very strange disease, that's the first time to you hear, and during all your life study of medicine and in your study of eMRCS, mostly about 80 to 90% it is wrong. It's the wrong answer. Okay, except if you find it by exception, you find it right. Okay. So which of the following statements related to the use of human albumin solution is false? Use between D and C and D and E. Yes,
And
hepatitis
E.
C remains a concern when large volumes are infused. No, you can give in hepatitis C. It needs to give human
It must
albumin,
be
no
given.
problem.
Yes, if
No
it was
problem.
about blood
As
transfusion, about whole blood
yes.
transfusion, it may be a concern. But this is a plasma.
As long as you're
albumin.
giving, as long as you are giving salt-free albumin for patient with hepatitis, not related to the volume. Yes. Okay. So you are giving salt-free albumin, so no problem for the patient. Especially salt-free albumin you are giving for patient with hepatitis.
Okay, so hepatitis, yeah.
Next question. Dr. Sarah.
Use of which of the following muscle relaxant is at least likely to result in histamine release? Atrachromia. I think we've gone through a question like this before. Am I out? Hello.
Yes, etrachlorium.
Yeah, we've dealt with a question like this before.
But etrachlorium, which is the most likely here, it is the least likely.
Likely, okay. Yeah, succinylthonium.
Succinylthonium.
Hello.
Yes, sorry. The most common, we have the same question, but what was the most common one? What she calls histamine release, and he say he bring only one from the family of atracheum or atracorium, tivacorium, doxocorium, or mivacorium, all the same family, and all the same have the same problem. By the way, and maybe also it's my mind in exam if I have a problem with a question like this, and I found mostly the same family in most answers, so I think I'll choose a strange family. So we have succinylthonium, we have a new idea, least one to have histamine release, and others the same family of the atracheum, all cause histamine release, so the most common one will be succinylthonium. Okay. I can't forget atracheum about 12 years ago, because I found one nurse get suicide by giving herself an injection of atracorium, and its name is the atracheum in the market. You know what it causes atracheum?
No.
What is the action of atracheum? This is a muscle relaxant. You give it before intubating the patient, like induction of anesthesia. Okay. So I tell you, but no one use it. Okay. Okay. It causes can just some noise background. Okay. It causes paralysis of skeletal muscles. Okay. causes paralysis of skeletal muscle. That's why they give it for the patient, and you have to beside you. You have your vent and your anesthesia device. So you just give it to the patient and put for him instantly the endotracheal tube and put the mask of operation to give him artificial respiration from outside. Trachorium is a muscle relaxant causing paralysis of skeletal muscles, including the respiratory muscles. And the person who takes this one, he can see you, but he can't breathe. And he can't move, but he can see you. Okay? No one try to use it, okay? Anyone would use it?
Okay.
No answer. Okay.
Okay. Which of
Next
the
question.
anesthetic agents? Sorry. Okay. Start. Which
Yes.
of the anesthetic agent listed below is associated with hepatotoxicity? Halothane, sevoflurane, propofol, ketamine, desiflurane. Halothane.
Not used for many years before. Now it is used only on developing countries and in developed areas, developing areas and low socioeconomic areas. Halothane is highly associated with hepatotoxicity, and now we are using sevo. Maybe sevoflurane is the most common used now in continuing anesthesia or in maintenance of anesthesia. Okay, did you hear about this before? If you are in operation, maybe when I started work about more than 12 years ago, they were using halothane, but they have to make sure that the patient, because sevoflurane was still so expensive and still not frequently you can find in hospitals. So they save only sevoflurane or sevo, as they say in anesthesia. Sevo, they save it for hepatic patients. Other than hepatic patients, they were giving halothane. But nowadays, halothane is not used at all. Okay, mostly not used at all. Halothane causes hepatotoxicity, and they are not using it nowadays. Next question. Who's next?
Okay.
Dr. Mahgoub, تفضل. Yes.
Okay, 22-year-old fit and well male undergoes an emergency appendectomy. He is given dexamethasone. An inflamed appendix is removed and the patient is returned to recovery. On arrival to the recovery area, the patient develops a tachycardia of 120 and temperature of 40. He has generalized muscular rigidity. What is the most likely diagnosis? This is a complication of dexamethasone, which is malignant hyperthermia. B is the answer.
Exactly. This is the most common, not the most common. This is one of the rarest complication of dexamethasone and a nightmare for the anesthesia team. Okay, malignant hyperthermia. By the way, most patients with malignant hyperthermia, most of them don't pass and die. Most of them, because you have nothing to do, and most anesthetist has not ready to face a problem like this, and this happens about one every maybe 1 million person. It's very rare problem, by the way. And most anesthetists I know, they passed in their life once or twice and the patient died. Okay. Hope you not face something like this. I just want to see the rate 1 in every 15,000. No, I don't. I think more than this. Or as I know from anesthetists, they haven't meet this problem many times. Management is dantrolene, by the way. Put it in your mind. I think I did see it once in recalls. Dantrolene is the antidote for succinyl. Management is dantrolene, prevent calcium release from sacroiliac reticulum. Next, and I think it's last question. I hope so. We get longer time in. Yes, last question. Who's turn, Dr. Ali?
Yeah. A 45-year-old man develops acute respiratory distress syndrome during an attack of severe acute pancreatitis. Which of the following is the not feature of adult respiratory distress syndrome? It usually consists of type 1 respiratory failure. Patient typically required high ventilatory pressure. Swann's Ganz catheter would typically have a reading in excess of 18 millimeter at G. It may complicate acute pancreatitis. It may heal with fibrosis. It's heal with fibrosis. This is common. It may complicate acute pancreatitis. This also happens with pancreatitis. And patient typically required high ventilatory pressure. Yes, because of going with respiratory failure. It usually consists of type 1. I choose Swan-Ganz, this one. It's not a feature.
Okay, what you want to tell you here?
Typically have readings in excess. Actually, I choose this by exclusion because all these things are right. It's just talking about the pressure. Yeah, this is wedge pressure.
The difference, if you have a patient with bilateral pulmonary infiltrates and bad X-ray, about chest bad X-ray, okay, you have the picture of two or close syndromes. One is the pulmonary edema or diffuse pulmonary edema or ARDS. Okay, in diffuse pulmonary edema, you'll find, or in cardiogenic shock, you'll find the pulmonary capillary wedge pressure more than 20, and sometimes 22. But in cases of ARDS, you'll find it normal or below 18. This is one of the definitions, by the way, of the definition of ARDS. Okay, diffuse pulmonary infiltrates with hypoxia, with normal pulmonary partial capillary wedge pressure. Sorry, partial capillary wedge pressure. With normal, you have to say partial capillary wedge pressure. Okay.
Yeah. Okay.
Right heart pressure is normal in this patient, and this is the low pressure in cardiac in partial capillary wedge pressure. Is it clear about ARDS and pulmonary edema? I think in recalls you'll find a question of pulmonary edema because in the PCWP will be more than 20. I think I did see this in recalls. Okay.
Yeah.
Clear?
Okay. Yes.
This is from part B, by the way. Okay, I think we finished. Yes, this is ARDS. Acute condition characterized by bilateral pulmonary infiltrates, severe hypoxemia, and O2 arterial partial pressure over FiO2 is less than 200, and I think we explained this last time. Clinically, or pulmonary capillary wedge pressure, keep in your mind. In absence of evidence of cardio or cardiogenic pulmonary edema. Okay, this is very important point you have to tell in the definition in part B. In absence of cardiopulmonary edema clinically or by pulmonary capillary wedge pressure, which should be less than 18. This is a complete definition. You have to say it in part B. Okay,
Yes.
thank you.
Thank you very much.
I'll close the record, and if there is any question, we can open together, not to make it so long. I think it's more than 2 hours.